I'm fine if you want to go ahead.
Alrighty.
All right, well, welcome everybody. My topic today is the presentation of diabetes, either type 1 or type 2. Next slide. And I use the American Diabetes Association criteria, and so to just kind of as a little background, you want to confirm these labs twice, unless it's completely obvious. But usually I will do 2 A1Cs that are greater than or equal to 6.5, 2 fasting blood sugars greater than or equal to 126, or you could have a 2-hour plasma glucose greater than or equal to 200 after an oral glucose tolerance test, or in a patient with the classic symptoms of hyperglycemia and a random sugar greater than or equal to 200. Next slide. Okay, you can go to the next slide. So, Mitra, I can't see the right side of my slide because I can see all of you, but it's covering up my slide a little bit.
Okay, are you able to click on the top of that and just drag it over to the side? Sometimes that'll help.
Okay.
Yeah, that's something maybe on your end. I wish I could fix that on my end for you, but.
Move it down, that's fine. So type 1 diabetes, what it really is it's characterized, it's an autoimmune condition that it eventually leads to complete destruction of these cells that make the insulin, the beta cells. And over time, your body doesn't have the ability to produce insulin. And so that's why these patients typically, they will need insulin. Sometimes there's a little phase of a honeymoon phase where they actually have a little bit of insulin still squirting out and being produced. And that can be anywhere from like 3 to 12 months, but most patients are rather quickly progress into needing insulin. And so they can present any different ways. The classic symptoms, they have increased thirst or polyuria, polydipsia. They usually will have some weight loss and sometimes will have some ketones in the urine or in the blood. Some people actually present already in DKA, and other people are asymptomatic and it's just incidentally discovered. Next slide. So with polyuria, I usually define that about greater than 3 liters a day. And so what happens is that when your sugars are significantly above 180, it exceeds the renal threshold for glucose. And so then they start excreting out sugar and having more frequent urination. And so about 90% of children actually will develop bedwetting when they were previously potty trained. They'll have nocturia, and sometimes their diapers, if they're very little, they'll have very heavy wet diapers. So those are things parents have explained. Polydipsia is due to the enhanced thirst because of increased osmolality and from the hyperglycemia and the low volume. And weight loss is usually from low volume, increased catabolism, from impaired glucose utilization, and therefore increased fat and muscle breakdown. The ketosis can also cause nausea and vomiting and anorexia, so that will be part of why they will lose a little bit of weight. And this is usually present in about 50% of children. Let me see, what else did I miss on the slide? So these patients, the classic new onset, sometimes they won't have acidosis, but they're usually present in the ambulatory setting. They don't appear great. I mean, they appear a little bit ill, but most of their symptoms are sort of vague. And usually those symptoms, the mean duration of symptoms is about 10 days. Next slide. So other people, they may present just having some like candidal infections, sometimes visual disturbances, long-standing hyperglycemia. They may actually come in with cataracts. Next slide. Next slide. So DKA is hyperglycemia with ketoacidosis. It's the second most common presentation in most populations, so about 30% of the population that presents with diabetes. With type 1 diabetes will have DKA. It's found more often in those with low SC status because they may just not have access to care and present later on before they develop it. And then that's usually with more severe symptoms. So they have polyuria, polydipsia, lots of weight loss, in a short amount of time. They may have fruity smelling breath, and sometimes they will have like drowsiness or lethargy. It also is associated with nausea and vomiting. And those children are hospitalized, they're rehydrated, and they start insulin therapy. Next slide. And silent presentation, next slide. So some people actually, we've had patients, I have actually a patient who has type 1 herself, and she has 2 daughters, and one was like 15 months, and she started noticing that she was like drinking all the time, and because she was just aware of the symptoms, she tested her sugar, and she actually found that her 15-month-old had type 1. And then within a year, her other child had diabetes type 1. So she was more in tune with it. So typically the people who are silently presenting usually have a close family member or just maybe a healthcare provider who might actually check it before they actually present. Next slide. Next slide. So type 2 diabetes, we're probably all more used to these presentations. It's the most common type of diabetes, so about 90%. And it's defined as a progressive loss of insulin secretion from the beta cells and in the background of insulin resistance. So initially, some patients can get away with maybe treating with orals or other injectables that are not insulin. And then over time, if they live till 150 years old, eventually they're going to have complete destruction of the cells and they don't make the insulin. But like I said, some people, can still produce the insulin. And so we call it like a relative insulin deficiency. Most patients present asymptomatic, and they're often found on routine labs, because we do these labs and their fasting sugars are up, and then we sort of start watching. So they can also present similar symptoms to, type 1. Some rarely will present with the hyperosmolar, hyperglycemic, non-ketotic state. With those patients, they have marked hyperglycemia, they're very dehydrated. They don't usually have ketosis, but some instances they could, if they're ketosis prone or have some kind of infection going on, and they appear more obtunded. Next slide. So just this kind of slide reiterates what we talked about in terms of differentiating between the two. And that I felt is on up to date if you wanted to go back and look at that. Next slide. And then just keep in mind that some medications can actually impair your glucose tolerance or cause overt diabetes. And I just put this slide in here so, just things for you to be aware of. Thiazides, a lot of our patients are on these anyway, so just kind of look at their med list and see what their risks are. Next slide. So I wanted to just give you a little bit of a case of mine that I had a patient probably in the last 6 months, 38-year-old nurse, and she had about a month history of blurred vision, and then more rapidly in the last couple of weeks before she presented, she was nauseous, she was vomiting, she was having abdominal pain, and she actually thought she had just some GI bug that she couldn't shake. So she was originally about 95 pounds, but she had dropped down about 20 pounds, so that was pretty significant, and family members were like, you got to get to the doctor, something's wrong. So when she came in, she was having a lot of thirst, she was urinating a lot, she was actually craving some sweets, and she felt just really run down and tired. So our medical history, just renal stones, endometriosis, and pretty much, family history was non-contributory. Just C-section, she was on no meds prior to. Next slide. So when she checked into the hospital, her sugar was 728, her A1C was 13.6. She was a little dehydrated, so her creatinine was up and her GFR was a bit low. Her beta hydroxy by BHD, I'm just going to say that because the word's difficult for me to say, but her ketone level, that's a ketone level, was elevated. She also had elevated urine ketones, and her venous blood gas was more consistent, with a high GAP and a low bicarb. Her C-peptide was low, and C-peptide, remember, that's one of those like precursors for insulin production. So endogenous insulin production is co-secreted with the C-peptide level. So if that is low, it seemed that, maybe the endogenous insulin level was low. Antibodies were done on the patient for type 1. She had the GAD65 islet cell and the zinc co-transporter. All those were negative. So she was treated with insulin drip, and her gap closed. She eventually was discharged. And now she is on insulin pump therapy with a continuous monitor, and her A1C is 5.6. Next slide. Anybody have an idea what kind of diabetes? Would you guess?
Type 1.
Type 1, right. Next slide. Okay, next slide. So she has antibody negative and beta cell function is absent. So they have this new key that's used. It's A negative, B negative. So antibody negative, beta cell absent. And so this is a form of type 1. Go ahead and put the next slide in. So even though you would expect her antibodies to be elevated, they weren't, and it could just be that we just don't know at the antibody to test yet. Maybe there's others out there that we just don't know yet. And so the clue for me on her would absolutely be like her rapid onset of symptoms, and just her body habitus to begin with. She was sort of a thinner lady, although that doesn't always, have to be true to be thin. Next slide. So, I've been doing diabetes for a good while now, and so over the years I've learned a lot of different things. Just a couple things would be, type 1 can occur at any age, type 2 can occur at any age. Obese patients can certainly have type 1. I do have a patient who's actually going through bariatric surgery soon because she's morbidly obese. Thinner patients can also be type 2. You don't always have to have positive antibodies to be diagnosed as a type 1. If you have a type 2 who's diagnosed and they just can't get controlled, on orals or injectables that aren't insulins and progress sort of more rapidly with weight loss, you may want to think about maybe they have type 1. Maybe they were in the honeymoon phase for a little while and actually have type 1. Type 2, I sort of more think of, slow progression to diagnosis, maybe patients who have a lot of family history of type 2, a gestational diabetic patient or had gestational diabetes in the past, and patients who are type 2 generally have high triglycerides too. If you have patients who have a lot of other autoimmune problems in your, like rheumatoid, celiac disease, Hashimoto's thyroiditis, you want to think about, is this possibly type 1, another autoimmune condition? And then ketosis, we always think of that as just type 1, but there are some patients who are type 2 who are more ketosis prone. Acute illnesses, can cause an increase in counter-regulatory hormones and further increase the insulin resistance. Patients also on like Jardiance type medications, those sodium glucose transporters. I've had a patient who was on that medication and put himself on an extremely low diet, more like a keto diet, and he ended up with DKA. And so those patients have a little higher risk of DKA. Next slide. I think that was the last one, guys. Yes. Any questions?
Thank you so much, May. That was awesome. And I really appreciate that case you sort of incorporated in there too. And it's interesting. But anyone have any questions, comments, or thoughts for Renee? I actually know someone who was recently diagnosed with type 1 diabetes, and she's in her late 20s, very thin and fit and everything. So that's really interesting. Any thoughts or comments? I see we got 2 more people join us while you were going through your didactic, so maybe we could have them do a little introduction as well. Katie Robinson, did you want to introduce yourself for the group?
Hi, I'm Katie Robinson. I'm a medical student working in Pocahontas County. Thank you so much.
And Donna Buchanan, thank you, Katie.
I'm sorry. I'm trying to do too many things at once here. Am I introducing myself? Is that what we're doing?
Yes.
Okay. Donna Buchanan. I'm the Disease Management Coordinator at Population Health here in Morgantown.
Thank you, Donna. Wow, I'm doing the thing where I speak when I'm muted. I apologize for that. But if there are any questions after the fact, as usual, just feel free to shoot me an email.